All right, we can probably go ahead and get started. Does that work for you, Esther?
Works for me.
Perfect.
Thanks.
Great, wonderful. So we can go ahead and get started. I will stop sharing my screen in a second so that you can see all of our wonderful panelists. But we'll start with a quick introduction just to get everyone familiar with what we'll be going through today. This is a webinar on the oncologist role in the digital pathology revolution. But as you'll see in here, we actually have a wide variety of perspectives included in this conversation today, which we're really excited to have. For a little bit of context, digital pathology tools, as I'm sure many of you know, especially some of the emerging tools such as diagnostic and prognostic algorithms, can help facilitate increased efficiencies and improve patient outcomes. But to date, many of the conversations around digital pathology space and the emerging tools have really focused on the pathologist and the pathology lab, which makes sense. It's in the name, and it's where a lot of this adoption has started. However, emerging digital pathology tools are increasingly targeting clinical questions rather than kind of focusing on the pathology efficiencies. And this creates opportunities to include oncologists in the discussion and increasingly hear those perspectives. Some of the conversation is also expected to be driven by pharma, who we have joining with us as well, who's working to develop actionable prognostic and predictive tools for their drugs that include or can include digital pathology tools. I'll pass off to Esther, who will walk through some more of background.
Yeah, and I think it also, and thank you for this introduction, Katie. I think it also started when we were looking at it, like how long does it take to make a final diagnosis? And also with a paper that has been published about 2 years ago now, in the meantime, that only 1/3 of the patients will get the treatment that they're supposed to get. So it's not only present in the US, but it's actually globally, right? It's occurring globally. And unfortunately, patients usually don't have like a long time to wait for the treatment to get an effective treatment. But even though when they're blessed to have this time to wait for an effective treatment, it's a mental and physical burden that weighs heavily on them, but also on their families and their friends. So, and one would believe that in this digital era that we would have got solutions by now. But unfortunately, we don't have that. So I'm really curious to learn from this panel and hear their insights, where they think, where we can use digital pathology and also how to involve all the different angles and different aspects from different perspectives, different roles, to increase the efficiency throughout the diagnostic decision-making process, as well as getting the right treatments to patients, not necessarily only drugs, but like true treatment with everything involved, patient management. Give it back to you, Katie.
Great, wonderful. So during this webinar, we're going to bring together these diverse perspectives from the pathologists, the oncologists, and biopharma as well, on what are the hurdles to tool adoption and how can we overcome these. We'll also share some insights from the lab medicine perspective, where we believe the digital tools such as the workflow and diagnostic tools, as well as the predictive and prognostic tools, can prevent deterioration of disease and death. We'll also have some time at the end for a Q&A. So feel free to drop your questions in the Q&A section. There should be a button you can push at the bottom or in the chat. Feel free to drop those in and we'll get to some of those at the end. I'm one of your moderators, Katie Maloney. I'm a principal at DeciBio Consulting, and I'm joined by Esther Abels, who's the CEO and founder of Solaris RTC. But before we begin, we can start by introducing our panelists. I'll start by introducing the two oncologists that we have joining us today. Firstly, we have Charles Gollan. Dr. Gollan received his medical degree from the University of Sydney School of Medicine. He completed residency training in internal medicine at Mount Sinai and then served as chief medical resident at Memorial Sloan Kettering Cancer Center. He joined Mayo Clinic as a hematology and medical oncology fellow before moving into an assistant professor role. And he completed a lymphoma and myeloma fellowship at MD Anderson Cancer Center earlier this year, and where he is now a hematological oncologist at Dartmouth with a focus in lymphoma. Next, we have Heinz Joseph Klupman. Dr. Klupman attended medical school at University of Dusseldorf and then completed his residency in internal medicine at University Medical Center of Utrecht. Dr. Klupman completed his training in medical oncology at the University of Amsterdam before becoming a clinical fellow in medical oncology at Westmead Hospital in Australia. Dr. Klupman has been working as a staff member in the Department of Medical Oncology at Amsterdam University Medical Center for over 15 years, and he also received his PhD in pharmacy at the University of Utrecht. Next are pathologists. We have Joseph Annunziata. He's a molecular pathologist, hematopathologist, and laboratory medical director. Dr. Annunziata was a hematopathology fellow at Columbia University before completing his molecular genetic pathology fellowship at Houston Methodist. He's worked as a molecular pathologist at multiple hospitals in Kentucky and was the former director of laboratory services at Kindred Healthcare and Scion Health. And then finally, with our we have Omar Perez. Dr. Perez graduated from Cal Berkeley, followed by a PhD in molecular pharmacology from Stanford University. He has over 2 decades of academic and industry experience working at companies such as BD, Pfizer, and GSK. Currently, Dr. Perez is at AstraZeneca, where he's the head of medical diagnostics of U.S. Medical Affairs Oncology. So we have a really great group, illustrious group of panelists here today. Apologies for me stumbling through all of that, but looking forward to get started. So I will pass back to Esther, who will get us started with questions.
Well, thanks for the great intros, and I'm very excited with this panel. So I'm looking forward to all the insights we're getting today. So what I would like to start off with is with regards to setting the scene a little bit more, how we're here with this full panel. So I would like to hear from, especially also from the clinicians, from your perspective, if you look at it like everything what has been implemented so far and what has not been implemented, how we can increase efficiency, how we can increase diagnostic decision-making. What is the biggest hurdle, actually, what do you think, for getting a definitive diagnosis to start effective patient management? I'd like to start with you, Joseph. You can unmute yourself. Joe? Yep.
Hi. Okay. Yeah. So I think that a lot of you're asking me about hurdles for implementation. Yeah. So the first thing that I would say is that there are a lot of different things that we need to look at in terms of digital pathology. Most of the community hospitals don't really have any digital pathology. So I would look to the oncologist's assistance in terms of prioritizing what's most important to them. From the laboratory side, what's going to be prioritized are going to be specific use cases like frozen section. And as the hospital systems get larger and essentially acquire more rural hospital systems, they're going to need digital pathology simply to review cases, because right now we're having cases that are being couriered for several hours' time. But the oncologists, they may be more interested in, even same as the biopharma side, in, predictive tools, for the companion diagnostics. So we just need to decide where we're going to invest, because it's very difficult to get the administration to sign off on some of these projects and fund some of these projects that don't necessarily have, one-to-one in terms of getting reimbursement.
Yeah, absolutely. Yeah. Thank you, Joseph. And maybe I can pass it to you, Dr. Gallen. I think that you have a little bit of experience in digital pathology, but primarily from the research side of things. And clinically, I know that it's not often a conversation the oncologists are part of. So maybe if you want to give us a just quick background in your familiarity with digital pathology, kind of the limitations or the current status of the oncologist's role in that discussion.
Sure. So my background is really, basic in terms of digital pathology interaction from when I was at Sloan Kettering, when they were developing PAGE for essentially standardization of the Gleason score in prostate cancer. And that was really the initial development, which was now like, several years ago. And I sort of have not been involved in that since then. I think for me, the biggest thing when I see a patient clinically is going to be confirmation of outside diagnosis. That's often the biggest barrier to me being able to initiate therapy appropriately for my patient. Almost all of my patients are diagnosed outside and come to me for some sort of opinion. And when I meet them, maybe half the time their pathology is not in-house, and I can only read to them what was provided to me on a report and not really be able to give them the insight, that they probably came to me for in the first place. So I think one of the biggest barriers is really related to the sharing of information and digital pathology being kind of a way for us to relay the actual slides and the blocks that a patient might have for us to be able to interpret in an efficient manner. And I know we talked about kind of the money side of things. Well, the biggest, money maker for us is really consultation. So if we can get all the patients' records and get their pathology reviewed in a rapid manner, we can fill our consultation slots faster and we can initiate treatment faster. Those are all, things that generate revenue for the medical center. And if we pose it in that sense to a hospital system where we'd be able to increase the workflow efficiency of consultation, which should result in increased revenue, it's probably something that might be worth investing in from that pure perspective. I don't know if I don't want to spend too much time or whatever your next direction would like to be, but I certainly have more thoughts to share as well.
Yeah, absolutely. I'm sure we'll come back to you in a minute. Maybe give Dr. Klumpen a chance to weigh in there. What's your experience or familiarity with digital pathology, if any? I know it's a little bit more limited. Where do you see the opportunity to provide value?
Yeah, thanks, Katie. So my familiarity is very low. So I have never worked with digital pathology, but there is a big need, I suppose. Dr. Golin has outlined very precisely what the problem is. And I guess what we need is to have the tailored approach, because it's not so much a question of if it's necessary or not. It's depending on the case, it's depending on the disease. So some diseases are in more need and others less, and some hospitals are in more need than others. As Dr. Golin says, I also am specialized in biliary tract cancer, and 100% of the cases are actually from other hospitals, and therefore the same problem occurs. But we have more issues with biliary tract cancer because not only the diagnosis needs to be reestablished, but also additional biomarkers or molecular targets have to be identified. And therefore, this might be a way, and I guess we can learn from each other. How can pathology help me as a doctor and the patient to move forward?
Yeah, and linking that back to when you mentioned those biomarkers, I'm also thinking now, Omar, looking at from the pharma perspective. If you look at that, we always think like, okay, we have an active, an actionable biomarker, but we're also trying always to optimize, because we find a lot of patients who do respond, a lot of them don't respond, even though they have an actionable biomarker, we think. So what do you think how these emerging diagnostic tools can help and address this?
Yeah, thank you for that. I mean, I would agree that patient identification is key to optimize not just the appropriate treatment plan, but when something of standard of care or newly advanced isn't available, they could be eligible for a clinical trial. So things such as digital pathology, whereas it can help improve efficiencies, maybe at the hospital site, maybe provide a concise and definitive diagnosis from the tissue to enable the medical oncologist to basically have all the information needed to make a proper diagnosis. We do believe that investment in advancing these technologies, such as digital and computational pathology, can help with that. There is, even in the US, which people view as very advanced in technology deployment and advancement, there are many areas within the community where timely diagnosis is not delivered, where pathology sites are sent out for secondary or tertiary consultation. And unfortunately, by the time the patient goes back to their medical oncologist, the physician does not have all the pieces to make a proper judgment call in terms of what would be the best tailored approach. So we do believe that digital pathology can help overcome some of these barriers. I think it's been highlighted by our panelists. There is the practical implementation aspect of it. There is a bit of a capital investment. There is, of course, ensuring that there's clinical utility from some of the tools that are being developed. But as we see the molecular landscape evolve across tumor types, with non-small cell lung cancer being something 20 years ago, which is basically histology based, squamous or non-squamous, to now 20 plus or so molecular subtypes, and you're seeing it across breast cancer, prostate cancer. You're seeing the cancers evolve as we generate more evidence. It's going to become important to harness this so that we can do comprehensive assessments up front, so that when the patient does come back, the treating physician and the multidisciplinary team has had a chance to really review all of the data to make any valuable decision and present that to the patient for a shared decision-making process. And so I think digital pathology is definitely one of these tools. There are logistical barriers, as mentioned, but as more evidence is generated, and particularly as we invest more in our clinical development to support some of these efforts, we hope that it will become a little bit more mainstream.
Yeah, absolutely. I appreciate that. And I think that it's interesting. It seems like there's this alignment that there's the applications for which it's primarily falls into the pathologist purview. A lot of these, facilitating pathology review, the remote consultations, the efficiencies that you can gain by implementing some of these tools. I'd be interested to hear from you, Omar, if you see an opportunity to incorporate the oncologists more in the conversations around digital pathology, particularly when thinking down the road, and this could be 4 or 5 years out, a CDX that is going to have perhaps looking at an H&E slide to make decisions there. How does the role of the oncologist change in that case? And is there any efforts being made now to work towards understanding how to incorporate the oncologist in those discussions?
Yeah, I think it's a very important point. I mean, the oncologist is clearly a critical stakeholder in helping inform and evaluate how the treatment landscape is changing. Guidelines today are changing faster and faster as the advancements of medicines come forward, and understanding what is current today, what could be projected in the next 2, 5, potentially even 10 years as treatments advance. That conversation is going to be critical, because every institution, whether you're in a top-tiered ivory tower academic center or a community practice or an integrated delivery network, you're going to need to bring forward capabilities or partner up with those who have those capabilities to offer the best patient opportunities possible. And that will mean incorporating technology. So having those discussions, I think, not just enables planning for better patient management, but it also opens up the door for collaboration. There is an incredible need for more integrated oncologist to pathologist two-way conversation. It's no longer the oncologist requesting a particular biomarker or a test, or the pathologist providing a report. This needs to be more interactive and dynamic. I mean, there's some real practical considerations for optimization, efficiency improvement that really needs those active discussions. And even in some of the work that we've supported, we're evaluating things like digital pathology as a tool that can help not just overcome these barriers, but help enable collaboration with molecular tumor boards. I mean, both parties can actually pull up a digital image and look at, here's the pathological diagnostic report, and here's the oncologist, the medical history, the treatment line, familial history, all these components, and together evaluate what might be a suitable path for a patient treatment plan. And so I think those types of integrations are becoming more important. This multidisciplinary team integration, it's no longer being siloed, and deployment across institutions varies, but I think this is definitely a tool that enables that collaboration. We've heard it from some of the panelists on board. It's like, for consultation, there are tricky cases to be read. Not everything is easy for interpretation, and some of these might be borderline, and that may influence whether or not you get treatment A versus treatment B. So I think, this is definitely an opportunity time for the oncologist to become not just familiar with it, but also be an active champion. They help drive a lot of treatment planning at given institutions, and work with their pathologist team to say, how can we help us in terms of better patient outcomes? And so I really think it'll help increase the dialogue. And we would like, for pathologists to be present at the molecular tumor boards, at the multidisciplinary teams. I know it happens in some institutions. I know it doesn't happen in a lot. And I think that's a prime opportunity where the complexity of treatment plans, it's no longer 1 or 2 options. It's multiple options that have to factor in medical history, molecular profile, germline and somatic testing. The evolution of markers is evolving very rapidly. Multiple markers are needed in order to make a treatment plan. And so I think that key collaboration point is necessary. And digital pathology is a tool that can help enable that from either primary diagnosis or even evolution to more complicated molecular biomarker readout from hopefully H&E stains, where you know, I don't know if we're particularly there yet, but I think, you know, the trend is going there. And or, you know, think about rural places that don't have access to pathologists, or other places where specialties and interpretation just don't exist. Like these are tools that can help decentralize this. And so I think it could really help revolutionize cancer care treatments in certain areas.
I really enjoy and listening to this, Omar, and I think these perspectives gave great insights. And I also would like to ask you, Dr. Annunziati, when you hear this, because you mentioned as well the oncologist role. The oncologist is an important stakeholder, and oncologists can be involved a little bit more. So how would you envision, if you look at this, how the collaboration would take place between the oncologist, the pathologist, and the pharma?
So at our institution, we have most of the oncologists are subspecialty. So we have various service lines like breast oncology, leukemia, lymphoma, and we have 3 molecular pathologists, and we've been appointed to kind of be the liaison with the director of medical oncology for each service line. We've split it up. So I think that's a good model. And, you know, periodically, quarterly or so often, you know, we review with the director of, like I'm women's breast and GYN. So like I'll review with the director of breast oncology. What are the biomarkers you want? What are the hurdles that you're encountering? NGS turnaround time, how's that? Case turnaround time, consults, synoptic reports. I'm on the committee for the COC committee for cancer, and one of the roles would be ensuring that the synoptic reports have enough information, that the biomarkers are being performed. We do a lot of tumor boards, so we get a lot of the word out at tumor boards, but there's also a lot of texting, phone calls, you know, based on which service line you're responsible for. I definitely coordinate with, we actually report to the chief oncologist. The laboratory is actually administratively, like the I guess vice president of the laboratory, or how you would call it, is an oncologist. So we have a direct line to you know, what we'd like to do in terms of digital pathology, AI or molecular testing. We discuss, you know, certain new and emerging technologies, and those that don't necessarily have, you know, a reimbursement, something that's more cutting edge. We discuss if certain funding is going to be deployed, because there is certain Cancer Institute funding or endowments, donations, that may be applicable to certain more emerging technologies or certain patient populations.
And would you say that with having the oncologist being the chief, would you say that would also change the setting with regards to collaborations? Because to me, it sounds like you're pretty advanced in implementing and using digital pathology, and how it's being used also for patient management more effectively. And I just want to mention, recently I heard that for example, in I think it was Singapore, that they also look at it like they have the meetings really set up, the tumor board meetings really set up to include digital pathology, focus on certain diseases, instead of like going through patient by patient, but really focusing on certain disease areas. So yeah, can you elaborate a little bit on that?
Yeah, that's pretty interesting. I would say that our institution isn't that advanced in digital pathology, but we're extremely advanced in terms of biomarker testing and CDX testing. We have a biomarker rotation. I sign out several dozen cases every day. PDL1, you know, HER2 for non-breast cancer, NGS, PCR, FISH, and IHC. And what we do is the molecular pathologist makes sure that all of the cancer patients get the complete list of biomarkers. So the oncologist has the opportunity to order the testing. The pathologist looks through and will add additional tests if needed, based on, you know, reflex policy, knowing the oncologist's preference, and also institutional protocol, these quarterly conversations we have with them saying, I always want an ESR1 for this particular breast cancer patient, stuff like that. But for digital pathology, it's mainly limited to the use of peripheral blood smear review by Celavision. In my previous 2 institutions, it actually was the tumor boards, which is where we started using digital pathology because we pledged ourselves to every tumor board, and there used to be 12 or 13, and within 3 or 4 years, there became 30 tumor boards. And we pledged ourselves to every single tumor board, even though they became increasingly subspecialized and difficult to attend. And by utilizing digital pathology, especially if you're academic and you have residents, it increases efficiency for the slides to get scanned, the resident to review it, the attending to review it, make sure that the resident understands because they're going to be presenting. And even in an institution like mine where we don't have residents, we probably have 15 tumor boards. And if we were to get digital pathology, perhaps a molecular pathologist could attend all tumor boards, which they don't. Perhaps a subspecialist could call in on a tumor board or at least make some annotations if they can't be present. And then a general pathologist, could have that like enhanced information. There are some hospitals right now where I call into the tumor board and I don't even have access to the pathology because we have differing LIS systems, differing EMRs. But if we had a unified approach to digital pathology, a scan is a scan. They could scan the slides. I can look at the slide in seconds. I can tell, what it is. But the difficulty is really ancillary testing, because the ancillary testing is still going to be performed on tissue. I think you mentioned about, or I think Omar mentioned about in the future, maybe we're not right there yet. Imaging would tell you we are there in terms of doing molecular testing on the H&E slide. Until you get to that point, digital pathology is definitely going to help you with the consultations and the tumor boards, but for the ancillary testing, if you're waiting on a community hospital, you're still going to have to wait for the block. But once you get it, I will say that there are certain reference labs that have a digital option. So at least once they perform that, let's say a PDL1 stain, you can review it digitally, and that will shave, in my experience, 3 days off of the result because I will review it digitally and then I'll just sign the case out. I won't wait for the slide to come back.
May I ask a quick question to this subject? So the question for me is, you have mentioned that in your lab you have 3 molecular pathologists. And so my question is, what usually in my experience happens is that the pathologist makes a review of the tissue, and when we have established that's the confirmation of the diagnosis, then the tissue has been sent for molecular analysis to another lab from the molecular pathologist, let's say. So how do you envision, or how do you work in your lab to get these 2, let's say, subdivisions of pathology? How do you get them closer and have less a delay?
Yeah, so we heavily rely on reflex testing. So we have 30 pathologists, and currently heme is a little bit better because if it's a heme case, most of the heme paths are also molecular pathologists, and we order the molecular testing, the FISH PCR testing up front without an oncologist order. Sometimes we call, particularly if it's whether or not you want to repeat NGS in a patient who's transformed or progressed. But at diagnosis, hematopathology, we pretty much just order the testing up front. But for solid tumor malignancies, we utilize reflex testing, particularly in colon cancer, thyroid nodules, non-small cell lung cancer, brain cancer. It's like we just order the NGS and the other biomarkers by IHC and PCR. We do have an in-house solid tumor NGS. In about a year, we'll have in-house heme testing. We don't have a very large panel, so some of the NGS does still have to go out to another laboratory. But if it's applicable, we can use our in-house panel. And we also offer, extensive IHC testing, HER2, PD-L1, HPV, which is all in-house, and some select PCR, single gene tests as requested by the oncologist. We offer what's the most commonly ordered, and our
Right.
turnaround time is very quick.
So if I understand correctly,
in-house.
then you have achieved actually the goal of combining immunohistochemistry and molecular analysis in a short period of time.
Yes. So what we do is in the LIS system, we have something called, colon panel, lung panel. And in
Right.
parentheses, it'll say everything. Lung panel is PDL1,
Yes,
IHC,
I understand.
HER2 IHC, EGFR PCR, NGS. And then the surgical pathologist doesn't even need to know. And then you can update that panel if, let's say, an additional CDX came out and there's a biomarker. You could edit on the back end, add that biomarker, and the surgical pathologist would not even have to know.
Right. So that's, sorry, Esther and Katie, I have another question. So the next question is about the algorithm. So let's say for biliary tract cancer, you might be aware there are like small duct and large duct, and they predict if certain molecular markers are present or not. So we talked about the financial part of it as well, because sometimes you do not even have to do the test because you can predict what the outcome might be from the immunohistochemistry. So do you actually use, or do you see it as a feasible thing to use algorithms in the step process of pathology analysis, which tests are, let's say, good to use or financially attractive to use?
Yeah, I think that's definitely helpful. In the example of biliary tract cancer, I'm not sure that we're there yet. For us, most advanced stage solid tumor malignancies, we send out for whole exome, whole transcriptome sequencing. And if there's any relevant CDX biomarkers, we send to Caris, they'll perform any relevant IHCs. But I do think that it would definitely be helpful where applicable to employ techniques to stratify the testing, because there are a lot of certain cancer types where essentially we just send for the biggest panel we can. We don't really think about it. And this would be a non-reflex. We don't have like a particular reflex test in biliary tract cancer. That's an example. There are other cancer types where it's pretty much up to the oncologist right now. And, we really only maintain the reflex testing where essentially, all non-small cell lung cancer or all colon cancer stage 3 and 4, it makes sense to do that exact panel in every
Right.
instance. So there's really only 5 cancers that have a reflex.
Great. Thank you for, I appreciate you jumping in, Joseph. I like the collaborative conversation, and thanks for walking us through that, Joseph. Maybe jumping to you, Charles. I think that, and Joseph, I'd be interested to hear your thoughts in this as well. To date, the role of the oncologist in digital pathology adoption has been quite limited, right? It's really decisions that are made at the pathology lab level, pathologist level, lab director level. And I guess my question to you is, what do you need? What tools, information, data do you need to better or help drive or engage with digital pathology, help, drive adoption of it within your institution, or at least have those conversations with the pathologists around the tools that they're using?
Sure. So, I mean, for me, with lymphoma specifically, a big part of my assessment for patients with mantle cell lymphoma, for example, which I focus on, involves risk stratification that incorporates more than just pathology, but it also will involve molecular data altogether. So I need something like a Ki-67. I'll need a tumor genomic profiling with specific mutations in mind. So there's, I think one of the conversations that would be helpful to have would be for us to be able to integrate within the digital pathology all the tools that we currently use in our minds when we're doing the consultation for risk stratification. So just immediately when I'm seeing a mantle cell patient, I know if they're low risk, intermediate risk, or high risk, because that'll affect what I do for this patient and what particular characteristics they might have. Right now, I get all these bits and pieces from different parts of the story and kind of synthesize them together when I meet the patient. But it would be great to be able to have all of that together. And I just think it's just a little bit of a disconnect, because sometimes my pathologist will know exactly what I want, but others may not. And so I think there's just a little bit more collaboration that could exist there for us to develop these kinds of tailored approaches.
If I may add, I guess there are two things essential here. One is what is available of digital pathology, so what tools and what is there, what's out there. And the second is, what does my pathologist know about it, and what has been the hurdle so far not to use it. So when we have these two items together, then we can talk about if we can merge my needs and the needs of the patients to the facilities which might be available at the hospital.
Yeah, and I appreciate those insights as well. And I hear that there's sometimes still a little bit of disconnect between interdisciplinaries. And that's where I also think, like, maybe, and I'm also looking at you, Omar, and yeah, I would like to hear actually all of your perspectives. Can pharma somehow drive this collaboration? And I'm just coming up with one example with PD-L1. We all know that there are several clones out there, several assays out there, and they all have a different methodology how to score. So pathologists are working with that. So how is that then interpreted by the oncologist, and what treatment is given, and why is there from pharma also these different perspectives that you have a different assay with a different treatment? Can we somehow improve that, or make that more efficient, or becoming more agnostic, more or less, so to say? So is there does any one of you see how we can overcome that aspect to create that collaboration that these four disciplines, three, will optimize this collaboration and for patients?
Yeah, Esther, maybe I can jump in and just highlight some of the areas that pharma can help facilitate some of this, particularly with the PD-L1 example. I think we've learned a lot. And before I kind of share my general thoughts, I mean, in the development stage, when you're developing a biomarker that may become a CDX, it's very specific to that trial design, that patient population. Hopefully, the efficacy and safety, deliver. And so you go forward filing. But when you get out into the real world, if the medicine makes it through the regulatory approvals and there's competition in that space and multiple pharma entering the same space, I think the PD-L1 lesson really helped us understand that generating multiple clones on multiple assay front with multiple different vendors really doesn't help a lot of people, and particularly confuses not just pathologists, but probably drives a lot of oncologists a little bit crazy. I think from that example, pharma did help work with external entities, particularly some professional medical societies, such as the Friends of Cancer Research Network, to build a consortium to evaluate, hey, we got 4 or 5 different clones here. No one's going to order 5 different tests because tissue is always limiting. They need to make rapid decisions. How can we help? And so that was a multi-year effort to help develop concordance data, platform comparison data to see, are they interchangeable? Now, that's one example. In other cases, we are realizing, and different pharma have different philosophy in these. So I'll just share my personal view on this, is that on the diagnostic front, we shouldn't technically be competing on that front. We can compete on the pharma drug development side, but from a patient identification purpose, we shouldn't be contributing to the noise. And so that gives us a lot of opportunity to work with not just organizations such as Friends of Cancer or the Personalized Medicine Coalition, to help drive some data generation to help inform, yes, these are very similar, here's a concordance determination, you can make an informed decision, but also work with testing guidelines to help them evaluate, to enable more opportunities. So there is I think a lot of data gaps that exist when something is first approved, and it's something that we are very keen for because we evaluate, here's what's happening in development. If they were to be regulatory approved, then we evaluate what happens in the real world. And we need input from panelists who are here present, from the academic centers, from the community centers. And we literally understand barriers at multiple different tiers and say, okay, what from particularly a US medical perspective can we do? And some of it's generating the data and the studies to show equivalency or comparability. Other times it's working with professional side like CAP to generate proficiency testing or other quality assurance methodologies, which exist more outside of the US to enable controls or things. So it is important for us, I think, as an industry to evaluate when these medicines go forward, because if there's an opportunity, there's probably going to be more than one available treatment. How can we help standardize a little bit of this so that it's easy for someone, particularly a medical oncologist, making a request that they may not know the exact clone that was associated with that particular trial. You know, and reference labs may offer multiple things. And so they can pick everything or just pick the one they want. And there's opportunities for missing patient identification in that regard. So I think the standardization, working with these external organizations, convening roundtables of experts to put forward, you know, white papers or consensus statements to say, hey, here's what's happening. Can we work together? And I've seen, because I've been part of some of these steering committees, a lot of the pharma have similar goals in this respect. So you see partnerships evolve when it comes to this aspect of it. And a good majority have aligned that, you know, on the diagnostic front, it doesn't make sense to introduce multiple tests for the same thing. Can we just cross leverage? Now, there are pharma who don't believe in that philosophy, and so that creates a little bit of barriers. And so, but I think as we evolve, and the need for focusing on implementation of reflex testing protocols rather than making sure that whoever is ordering a test picks the right requisition box. You know, we should be focusing on that, because that time frame, I think, has been mentioned several times. Getting all the information to make a first time in treatment decision is critically important, particularly for late stage cancer patients. So there are tools that can work, but of course, it's working through these consortiums, working with the medical societies, generating the evidence to give them the ability to make guideline considerations. Those are things that pharma can support.
Great, wonderful. No, I really appreciate that. And actually touching on one point that you touched on there has brought up previously, and also someone mentioned it in the Q&A. So I wanted to touch on this, and anyone can feel free to answer. But we would love to hear thoughts on how we think the digital pathology tools, in particular, the scanning and algorithms, can help improve the turnaround time, that time to treatment decision. How does the collaboration that's facilitated by those tools help shorten the time from when that test is originally ordered to the time that the patient receives treatment? Joseph, maybe if you want to go ahead.
Yeah, sure. So I definitely think that digital pathology improves turnaround time in different scenarios in different ways. In particular, starting with the consults. So if I'm receiving a consult from an outside hospital, now the barrier is that, you know, they need digital pathology, right? They need to be able to scan their slides, and then I also need to be digital pathology capable to view them. I at least need to have a viewer. So I received a consult last week. You know, had it been scanned and had I had a viewer, I think it took 3 to 5 business days usually to receive it. So it would have cut down by a week. I did do additional stains, but even without the aid of additional stains, I was able to come to a diagnosis. Most of the stains that I wanted were already done. And that's number one. Number two, when I added NGS, I could have cut down 3 business days time, because rather than have them send me the block, I could have said, you know what, additional IHC is not going to help me. Send the block to X laboratory for NGS testing directly. Don't send it to me and then we send it there, you know, if you don't mind, because that could save time. I think that the other ways is any tools. I mean, there are a variety of different kinds of tools, but you know, the one that I'm most familiar with in the beginning is for prostate. It's also to improve and enhance accuracy and harmonization of the Gleason scoring, but it also speeds up report generation because these reports have all these detailed bits of information. And there are actually some small digital pathology companies in India that have a viewer that pretty much just focuses on the prostate. And if you use their software, you could generate a report in probably 1/5 of the time. So it definitely increases efficiency. And if you're in a pathology center that really has a lot of cases like we do, it could probably improve turnaround time by 2 days just by the mere fact that we can get through more cases. I myself have 2 cases that I've looked at, but they've been on my desk since Monday. I just don't have the time to sign it out. But if I had a particular AI tool or something, whether it was something to help me generate the report, to write the report, or something that, you know, there are certain AI tools that attempt to make predictions or diagnoses by flow cytometry. So I imagine in the future, there may be something that evaluates a follicle and a lymph node and tells me, is it abnormal or not, which makes me think, do I really need flow cytometry? Do I need follow-up FISH testing? So I think like there's endless opportunities in terms of AI tools, but just in terms of scanning, it probably reduces by at least 3 or 4 days the turnaround time for consults. And also, if you send out most of the rural, Midwest, central part of the United States, some of those practices actually don't even have IHC. Or if they do, they may have a keratin, 3 and 20. They don't have PD-L1. They send to a reference lab such as NeoGenomics. And if they use their viewer, which you don't even need to be digitally pathology capable, you can cut the turnaround time by 2 or 3 days by viewing certain slides. And you can coordinate with your oncologist as to which ones they may need it faster. But for me, I just make the decision, you know what, it's a biomarker. I'm doing the biomarkers digitally. And if it's something just like that I just need for the diagnosis, then usually the case gets held because we have an extensive suite of IHC, but we can't keep, the rare IHC markers that you only need to make the rare diagnosis. So the difficult cases definitely get held up longer.
Great. It looks like Heinz-Josef, you want to add something there?
Yeah, I just wanted to question. I'm aware that there is a trial in the COVID time of validation of digital pathology, but I'm not quite sure if that has been done in oncology. So my question is, would a randomized controlled trial to prove the benefits of digital pathology, would that help to integrate that tool into clinical practice?
Perhaps I can jump in. So I think there are current studies evaluating this in a prospective manner, particularly novel quantitative measurements for computational pathology. There's actually some presentations coming up this weekend at World Lung, if you're attending, that will highlight this and upcoming at ESMO later on this year. So there is active work on the pharma side. AstraZeneca is definitely invested in one of these technologies as a way to better identify patients and to better predict responsiveness. So there are active efforts to demonstrate the clinical utility of these tools. And hopefully they can, at the end of the day, provide better options for patient management. And so there is a lot of good upcoming work. So stay tuned as it's upcoming medical conferences.
Yeah, and maybe I have one last question that I will kind of building on that before we jump to the Q&A. But it seems like a lot of the things that you mentioned, Joseph, and that you just touched on, Omar, they have the potential to not just increase efficiency in the lab, but actually, saving time to receive those test results could have an impact on clinical outcomes for patients. And I think that's what you were alluding to as well, Heinz-Josef. And to date, historically, we've seen within the digital pathology space that adoption is slow. It's taken years and decades, and we're still, by no means is digital pathology a ubiquitous tool. So my question to you is, given some of these benefits that can be derived from digital pathology, to what extent can oncologists become champions of digital pathology and help drive adoption within their institutions? Is this can the labs overall or the industry as a whole benefit from incorporating more of the oncologist perspective in the at an institutional level in these decisions around whether or not to adopt and bring these tools in? Anyone can feel free to answer that, but would love to hear thoughts.
If I may start, medical oncology is the champion of evidence-based medicine. And and that's the basic rule of everything we do. And if we don't have evidence that it's better, then we don't implement it. And we recommend to use it in clinical trial. As Omar said, well, there are clinical trials coming up, great. But they have to keep in mind that's the steps we take. And as soon as there is a positive randomized controlled trial, then we will implement it. And then we will be saying to our pathologist and wherever we are, we need this. And I guess the other way around, what you mentioned is, so what can we do now? We can wait, or we have patient advocates. I guess that's the other force, which is really, especially in the field of biliary tract cancer, patient advocates were the ones who initiated and financed the majority of clinical trials before we had any evidence in this field. And so we should not underestimate the power of patients in that field.
Great, lovely. No, I appreciate that. I think that the point is heard that it's not just enough to have these claims of cost savings or time savings or efficiency. You need the data to actually tie that to the clinical impact, which I think is still a gap in the space in a lot of regards. Anyone have anything else to add there? Otherwise, we can jump to some of the Q&A questions. We have great questions that came in the chat, and anyone else on the line, feel free to drop questions in. We won't probably get through all of them, but we can maybe follow up with some of these after the fact. Maybe I can get us started with the first Q&A question, and then Esther, feel free to jump in after. I think this is something that we have a lot of conversations around, and maybe Joseph, you'd be the best person to take at least the first stab at this. But I think a lot of the conversation today focused on the benefits of digital pathology and where it's providing an improvement to the workflow or the efficiencies. But we know that, like I mentioned, digital pathology hasn't been widespread. We haven't seen widespread adoption across all institutions. So what in your mind are the biggest barriers to wider spread adoption and usage of these tools?
So I would say that first and foremost, for our institution, we're switching LIS providers. So if you don't have a firm established EHR and LIS, if you're going to be moving, you're going to kind of delay adoption. So, from an IT standpoint, your infrastructure has to be maintained intact without any changes. So we're not even looking at digital pathology until next year and beyond. The second thing I would say is it's definitely the financial impact. If you look at it from a financial perspective, most digital pathology, there's an associated cost. I'm not sure, how many of the different tasks that we can perform are reimbursed. We do receive consults, but most community hospitals don't, or some integrated delivery networks, they receive consults quite locally. And I think that, the academic institutions that do receive consults, at least the ones I've been associated with, they definitely do have digital pathology. They have it for tumor boards, they have it for reviewing consults, and it's very helpful. But I think that, in the community side, there's definitely more barriers to adoption, and there's definitely less willingness to adoption. And there's even less in, the private practice community side. But I think that, as there becomes increasing centralization, or, whether it's an IDN or a private practice picking up more and more hospitals, then they start to have to do tumor boards. Then they start to have to shuttle around cases. And I think what's going to happen is that the barriers are going to become overpowered by, the increasingly complex logistics, and the need for digital pathology is just going to become too vast. And also, I'll say that while there is a cost, what the scanner, what the technology, what the hardware cost 10 years ago is not what it costs today. Keep in mind, in the early 90s, whole genome sequencing test cost probably $1 million. Now it's 1,000 or so.
So mostly I hear as well that we do need the evidence, and we do need the science, and we do need the data. And also, if we're driving it from pharma perspective as well as oncologist perspective, we want to see the outcome data as well as treatment outcome data. So thinking about that, how can what specific outcome data are we thinking of? So that's one of the things that we see in the Q&A section, but also how can oncologists help drive patient enrollment in these clinical trials, because they often know what clinical trials are going. They don't know if there's a digital pathology maybe involved. Is there an option to get digital pathology involved? So how can we drive that? What is specifically needed? And any one of you can answer it. Curious.
Difficult question, Esther. I guess historically, medical oncology or hematology are the drivers of clinical trials. I'm not aware of any pathology trial that they are the main driver of the clinical trial, let's say. But please correct me, Joseph. But so that's one of the things, and I guess somehow I feel it needs to be a side study and not a primary study. But I haven't had a thought about it. But I'm very curious what Omar promised us from the studies which have been performed. But the time and the amount of testing, so the correctness and the time efficiency, these are the main two factors which I think should score very high.
Yeah, I mean, I think I can add, I think there's been an incredible body of work done in a retrospective manner to evaluate, is this a suitable option going forward? Unfortunately, a lot of the reality is when you do want to go underneath the regulatory framework, you want to get something that's easily adoptable, clinically friendly, usable, and won't present a barrier to test adoption. So that in itself kind of prohibits brand new technology from being introduced, because then you spend literally 4 or 5 years trying to get adoption for that at the same time while patients are unfortunately not getting diagnosed appropriately. And so there tends to be a lot of these retrospective, maybe follow-on type of applications, and particularly from a pharma side, if it is a predictive biomarker that's associated on a, let's say, computational pathology software that's also on a platform, the regulatory requirements view that as a system. So you have to go through the scanner development, validation, the software pieces, the reagents, the whole package, and go through that. So it's a multi-step component. I mean, I don't think the US, just given the current Class 3 CDEX regulatory framework, is not designed for a decentralized plug-and-play model, even if we could define standardization across it. There are other countries who are doing this, particularly in the Asian markets, and EU somewhere in between. But so with that said, the applications are slowly upcoming. I think we're getting to a point where we're advancing our antibody drug conjugate, where there is no other ability to adequately identify the most benefit or responder patient population. So we have to introduce this thing. So what are all the necessary steps to get to? I mean, I can share with you that we have a publication in review at this point, understanding the barriers and perceptions to digital pathology and computational adoption in the US, a very comprehensive assessment. And in that body of work, we came to the estimation that there's only about 10% usage. And right now it's tiered towards a high volume laboratory because there's efficiency economies there. But the mainstream hospital systems, unless you're an MD Anderson or a Sloan Kettering type, you may not have access to. As the content builds, as we get more of this evidence generation, clinical, phase 3 randomized controlled trials out there, and we build more than 1 or 2 or 3 markers, you start to see slow adoption. But if you just look at it, NGS, I mean, some of us here remember when it was single marker, it was IHC or FISH, and when NGS came onto the scene, it wasn't until you had 4, maybe 5 predictive markers that you started seeing a switch in the pendulum. And of course, proper reimbursement structures. And I mean, it's only been since 2018 we can get NGS really reimbursed. 8 years later, we're still kind of struggling. So there's a slow adoption rate, but I think as we're noticing, particularly with not just monotherapy, but combination strategies to better identify patients who may not respond to IO therapies out there, which are some standard care in certain indications, we need better tools to identify these patients. And some of these quantitative computational are a means to do that. And so I think the next 5-10 years is very rich. We haven't even had the opportunity to discuss the implementation of AI tools on top of that. So there's an infrastructure bill, and I think Joseph put it out very nicely. The scanner equipment, the IT infrastructure, the training, the specialty. I mean, estimates could be anywhere from $500,000 to $1 million for a laboratory to adopt that CapEx, and then they need a volume to sustain it. So those are large volume places that can afford something like that. So the costs will drop, and hopefully in 10 years, it follows the same sequencing pattern where it drops significantly. But you have all these barriers up front. But I think as advancement in precision medicine is moving forward, and we're seeing it across different tumor types, that evidentiary pieces will come up forward to help drive us. I don't think we're at the tipping point. There are companies who are pioneering components of it, and give them great kudos for working out the first, 510(k) clearance from the FDA, going out to Europe, now moving on to Asia and others. So there is a slow momentum, but clearly studies that demonstrate that these tools help better patient management, reduce time to the first treatment, and eventually improve outcomes, which we all want to see. That will all help. So all those evidentiary pieces is something that we think strongly of, and we're working with others in the community to get to. But it is going to be a journey. And so, but I think everyone is hopeful, because we all evaluate that for patient care, that this is definitely going to help improve lives. And so we're all very excited for that.
Great. Wonderful. Well, thank you so much, Omar. I think we can end it there. I know we're over time. Really appreciate all of the perspectives from all of our panelists today. It was a really great discussion. I think it's great to get these perspectives in the room together that may not otherwise be shared in a single forum. And I think we had a great conversation. So thank you to all of our attendees for dialing in today. Thank you to our panelists. Thank you to Esther, my co-moderator. And yeah, thank you so much.
Thank you.
Great. Thank you.
Thank you.
Thank you.
Bye.
Thank you.